NBS. Always.
Good morning and welcome to NBS, and we are having a breakfast meeting right about this time. It is the first day of December, and we do know that on 1st of December we commemorate World AIDS Day. We don't remember, we don't celebrate, but we commemorate it because we're trying to look at how far we have gone in ensuring that this stops or at least is subsided. With me in studio is Dr. Andrew EDIELU, and he is a program manager with PREFA, which is protecting families against HIV and AIDS. Good morning, doctor. Privileged to have a doctor in studio.
You're welcome. Good morning, Mildred.
I am very great.
Yeah.
World AIDS Day is here. First of all, let's take a look at the theme and how does it rhyme with the fight against HIV and AIDS currently?
Well, the theme today is getting to zero, which really reflects the overall fight that has been staged against HIV. As we talk right now, there is a document which we can call a strategic plan that is guiding the fight against HIV/AIDS, and it's a UNAIDS document called Fast Track.
Okay.
And in Fast Track, it outlines a series of targets that must be achieved first by 2020 and then next by 2030.
Okay.
And by the end of it, it's hoped that by 2030, HIV will be no more. The epidemic will have been eliminated. So, talking about those targets.
How realistic are the targets?
Well, the targets have been drawn out of projections regarding the trend of HIV initially, what has been done, and where the interventions how the interventions reduced the HIV transmission. And then from there it's projected that if we added a few more interventions, if we stepped up what we are doing, at what level would it be after how many years?
Okay.
So that is the basis of the targets that we set.
You work for PREFA, preventing families against HIV and AIDS. What exactly do you do? Which strategies do you take to ensure that you live up to the expectation of your name?
PREFA is protecting families against HIV/AIDS, and our niche since inception, that is in 2004, has been really entirely on PMTCT.
Okay.
That is prevention of mother-to-child transmission of HIV. So, that being our niche, there are lots of other activities that relate to EMTCT that we engage in. But first, let me begin with the EMTCT.
Do we have a difference between the PMTCT and EMTCT? Elimination and prevention.
Well, elimination is a target in itself, while prevention is a means to achieve that target.
Okay.
In elimination, the target is that by we want to achieve less than 5% transmission of HIV from the mother to the child. So a series of steps are undertaken, a series of guidelines are in place, and those can be grouped as aimed at preventing mother-to-child transmission. When those interventions reduce the HIV transmission to less than 5%, we shall say that we have achieved elimination of mother-to-child transmission.
How does the prevention of mother-to-child transmission of HIV work? To a common Ugandan out there who prefers, most especially the rural women who prefer giving birth at a traditional birth attendance area, it doesn't seem real. What profiles do we have? What are the facts about PMTCT?
The PMTCT begins from pregnancy through delivery up to the time that the baby is breastfeeding and eventually is stopped from breastfeeding. A series of achievements have been made in this, and currently the practice is what we call option B+.
Okay.
And option B+ represents a set of guidelines. And under this arrangement, any mother, be it pregnant or breastfeeding, starts ARVs immediately after being diagnosed. Now, this is slightly different from what is in the general population. We know that in the general population, when to determine whether somebody is eligible to start ARVs, we do what we call a CD4 count. Now, a CD4 is a type of white blood cells.
Yeah.
And we know that white blood cells are critical in fighting infections.
Trying to get back to my science.
Yes. So, when HIV attacks the body, it actually attacks white blood cells and among others, what we call the CD4 cells.
Okay.
So the amount of CD4 cells that an individual has is the measure of the strength of their immunity. So
the lesser the CD4 cells you have in the body, the more prone you are, you become weaker. Okay.
The weaker the immunity, the more prone someone is to other infections.
Which count do we base at before you could actually determine that I need to take ARVs or not?
This has evolved over time. Previously, we took a count of 200. If somebody was below 200, we said this person should take ARVs.
Yes.
Then it went to 350. And right now it's at 500.
Okay.
But that does not apply to the pregnant and breastfeeding mothers. For pregnant and breastfeeding mothers, we say as long as a mother is HIV positive, they start ARVs irrespective of their CD4 count. And that, in essence, aims at ensuring that the mother's immunity is preserved, and two, the amount of virus, the amount of HIV in the blood is reduced, what we call the viral load. So under those circumstances, because the chance that the mother has of transmitting HIV to the baby is dependent on the amount of virus that is in the body. The higher the amount of virus, the more likely the mother is to pass HIV to the baby. How
is the arrangement of PMTCT in the Ugandan setting? How does a pregnant mom who doesn't even know probably she's HIV positive, how does she get to know about this? How does she get the services? Right now, the PMTCT program is organized at various levels, playing different roles. Overall in charge of all the health programs in the country is the government of Uganda, which is represented by Ministry of Health. Now, under that, we have various donors, like the biggest of which is the US government, really. But we have also others like UKAID and quite a number. So those, we collectively call them as, they are called donors. Then those donors have what we call implementing partners, which is basically a set of HIV organizations, PREFA inclusive, that connect between the government and the final people who need the service
as well as the district.
So does a Ugandan get this from any health center, or specifically there are health centers that do provide that?
Now, this whole system that I've talked about, the government of Uganda, the donors and the implementing partners, actually works to support what Ministry of Health already has, which is the health facilities.
Okay.
And there are quite a number of implementing partners. Others support the private health facilities, others support the private not-for-profit, and others support the government facilities, such that at any service provision point, it's practically covered.
Okay. What are some of the challenges that you've faced while trying to implement PMTCT?
Well, quite often the challenges are down to, let me begin with the community. We know that whatever appears at a health facility is simply a tip of the iceberg of what is in the community. So one of the challenges is that most of our interventions target health facilities, but connecting what is taking place at the health facility and what is taking place in the community is quite a big challenge, because we know that there are a lot of, a big driver of what takes people eventually to the facility is what happens in the community. So if the community problems are not addressed, then we are bound to still have a challenge.
Okay.
And so when we look at the facilities, particularly in the respect of prevention of mother-to-child transmission, we talked about the fact that a mother has to start ARVs as soon as possible, immediately. And that has to continue for life. It's not that after they have delivered,
and the CD4 count is still high?
And the CD4 count is still high, we stop. It doesn't work that way. Once they start, they continue for good. So it is very important, therefore, that a mother has to remain on the ARVs.
Okay.
However, you find that you start a mother on ARVs, and 2 months down the road, you can't find her. 6 months down the road,
follow up.
Yes. So that is a situation we call loss to follow up. You have a mother whom you started in care, but for one reason or another, you can't really trace them anymore.
Okay.
And that has partly been driven by one, stigma. And stigma leads to non-disclosure of the HIV.
It's still a curse to have HIV in our societies. Or you're bewitched. Do we still have those kind of illusions?
Well, we have come a long way in ensuring that that myth is put off. But right now, what some people hold is not really so much on the side of the myth, but on the psychological perspective of being labeled by the society that so and so has HIV. So
that promiscuous. Interestingly,
that also sometimes comes up. And so, like any disease that somebody may have for a long time, what we call chronic illnesses, there is a lot of adherence to the guidelines that has to be practiced.
Okay.
There is a lot of adherence to the medication that has to be followed. And therefore, that person needs psychosocial support.
That's very
right
true.
From home up to the health facility.
Well, finally, Andrew, I would ask, what can be done? I know you have some achievements, which we'll of course mention as we wind up, and what else can be done to ensure that getting to zero, we get to zero new infections, we get zero discrimination, as well as zero deaths to HIV-related diseases?
Now, it is all a collective effort, and so far, I should say we are having progress, and we are moving in the right direction. First of all, a lot of coordination of all the implementing parties has been improved over time. That is right from Ministry of Health. Everyone knows their role, the implementing partners, the donors, the health facilities.
Okay.
So that coordination mechanism is very important. But also, there has been, with that, a lot of teamwork has been built between the implementing partners and the facilities and the final beneficiary.
Okay.
But also for Uganda, we have quite a lot of political support, which we have ridden on to be able to achieve this as well. And to mention more specifically, the office of the First Lady has really been the lead, and quite often in the EMTCT circles rather, the First Lady is referred to as the champion.
Oh, that's interesting.
Yeah.
Okay. Well, thank you very much, Andrew. We would have loved to discuss this on and on, but I should say we'll take on this discussion on our social media platforms. At NBS TV is our Twitter handle. Go ahead, spread the gospel. And NBS Television is exactly our Facebook page. I've been having Dr. Andrew EDIELU. I must say I've learned some technical words, if I would call them technical, medical words, from Dr. EDIELU right about now. Please go and test. Today could be the day that you will decide to get to know the truth. Go and test, and if you are a pregnant mother and you find out that you are positive, please go ahead and adhere to the medication given to you by the physicians or by the doctors. I am Mildred Tohaise. Let's wrap it up at this point in time. Let's continue with the commemoration of World AIDS Day. If you can get yourself a red ribbon, please wear it all day. Good morning.